So, welcome everybody we've, to this fourth in a series of four lunchtime seminars being organised by the UK Prevention Research Partnership. I'm Philippa Hemmings, Head of Healthcare Technologies at EPSRC, the Engineering and Physical Sciences Research Council within UKRI, one of the funders of UKPRP. So just a few housekeeping before we make a start on this afternoon's seminar. Just to remind everybody that this meeting is being recorded, and indeed some of you may subsequently be listening to this on catch-up, as it were. Please do keep yourself on mute when we're not speaking and turn your camera off. You'll see that our colleagues have been doing that for us. That's to manage the bandwidth issues so we can all hear and see as clearly as possible. An encouragement to submit questions as we go for the speakers to discuss after the presentation. You can use either Slido, that's the event code 001949, and we've also got closed captioning available, and please find the stream text link in the chat box. If at any time you have technical questions, please do contact our webinar support team, hopefully, and I'm quite confident that won't be needed. So let's just do a quick reminder of the agenda. I'm giving you a little bit of an introduction now, and I'll say a little bit more about UKPRP. And I'm joined this afternoon by three speakers. Professor Sarah Ayres and Dr. Krista Bondi, both from Bristol University, who will be giving us a presentation on the TRUDE Research Consortium, one of the UKPRP funded activities. And then we'll hear from Angela Hans, and the Public Health Programme Manager in the Healthy Places and Communities team of the relatively new organisation that I guess Angela might say a little bit more about, the Office of Health Improvement and Disparities. And then if all goes to plan and on schedule, we'll have a Q&A discussion, and we'll be finishing within the hour as per the promise. So let me say a little bit more now on behalf of the funders about UKPRP, the UK Prevention Research Partnership. This is a £55 million multi-funder. There's 12 funders. You'll see the logos on the slide, funding initiative. And its aim really is to support novel research, and we see research in a broad sense, into primary prevention of non-communicable disease. As funders, we recognise this was a very important and underfunded area with a lot of really important questions and issues that we needed to tackle, at scale, so that we can help improve population health and reduce health inequalities. And critical to this, as I say, it's the focus on upstream determinants of a non-communicable disease, and all the activities we support, are all about co-production with involving researchers with public policymakers and professionals. Next slide, please. So we made the first set of awards as a partnership back in 2019, and gosh, quite a lot's happened by then. And today, as I say, we'll be hearing from the TRUDE consortium, but you'll see there's a wide range of issues, and I would encourage you, if you're not familiar with some of their work, to look on the website and the websites of the various consortia. And we also supported a number of networks. Next slide, please. And we've just in the last year concluded the activities of a second call and funded three further large-scale consortia. And again, I can't, in the time available, say much about them, so I'd encourage you to please do, if you're interested, look at the websites for more information. Again, and as funders, we're really pleased with the sort of, the exciting portfolio this initiative has helped to support. Next slide, please. So the focus of the fourth of this series of seminars is about making healthy decisions on urban development and planning. It was some time ago that the world switched from being more rural to more urban, and so many of us and so many people around the world now spend our time living and working in urban environments. And the conditions, as we all know, in which we are born, grow, live and work and age are key drivers of our health and well-being and health inequalities. And a very important part of this, which will be explored in today's seminar, is how we make healthy decisions on urban development and planning. Next slide, please. So some of the leading causes of ill health and death in the UK are non-communicable diseases. So as funders, obviously this is, an important problem that we want to tackle at scale. Um, and the speakers from TRUDE today will outline their work, and I'm going to say with far more detail than I'm able to, about some of the things that they're investigating and some of the things that they have started to understand through their activities. Next slide, please. So it's my pleasure now to hand over to the first of our speakers, Professor Sarah Ayres, and she will then seamlessly, during her slot, pass on to her colleague, Krista Bondi. Thank you very much indeed, Sarah.
Thank you for joining us this afternoon. This presentation is in 4 key elements. The first, I'm going to give a brief overview of the TRUDE project. Second, I'll explain how the work that Krista and I are leading on fits into that. Then Krista will explore some emerging findings from our work package, and we'll finish with a nod to next steps. So in TRUDE, we're interested in exploring the link between urban development and health outcomes. And in particular, we're interested in how urban development, and by that we mean infrastructure, transport, housing development, how that impacts on health outcomes. And in particular, we're interested in how it impacts on non-communicable diseases, the things you can't catch, like obesity, mental health, and asthma. We're also mindful that the impacts of poor urban design affect people disproportionately. So the poor, ethnic minorities, disabled people, young, old, and women. So a big part of our work is thinking about how we can try and reduce some of the health inequalities associated with poor urban design. So the overall aim of TRUDE is to think about how we can intervene in the system, identify critical leverage points to incorporate health outcomes at a critical time in the decision-making process before it's too late. We're a big transdisciplinary team. We're taking a systems approach, which means that we're bringing all our expertise to bear on the problem. We're a 5-year project. We have just finished phase 1, which is about mapping and understanding the system. Krista and I have been leading the work package on primary engagement, doing systems and workshops to try and understand this environment. We also have a team of economists who are producing economic valuations. When we think about urban development decisions, we're often thinking about active travel, green spaces, trees, but actually our economists and our teams are thinking about the full spectrum of health outcomes. So, for example, the ways that houses are designed can impact on alcohol consumption, can impact on domestic violence. Noise pollution can cause ADHD in children, leading to disruption in educational settings. So the costs of that ill health lands outside the health system. It falls on the education system. It falls on crime and disorder. So this economic valuation tool can be used as an incentive to bring a broader range of partners into the urban development decision-making process and thinking about health outcomes crucially. We also have a team of experts thinking about creative ways to give voice to those people most affected by ill health caused by poor urban design. So how can you package and present those voices in a way that is going to land with decision makers? So in our work package, in the first stage, we've been looking at mapping the system. What does the current system of urban design look like? You might be sat there thinking, well, don't we know all the problems and the barriers for why health is not incorporated? Do we need this big project to find out? Well, our response has been lots of the work to date looking at the barriers has taken place from the perspective of one particular lens, from the perspective of health or planning or Whitehall decision making. We're taking a transdisciplinary approach, looking at all of those perspectives. And we're also basing our work on rich qualitative interviews, asking people directly involved in the system their views, motivations, aspirations, so that when we come to design interventions and think about new ways of approaching these problems, we're working with the grain of reality, what's actually happening in our case study sites, not what we assume might be happening based on desk-based work. We're a big team in Work Package 1. We're working across 4 institutions. We have 8 data gathering teams working in the field of health, lawyers, real estate, political scientists. And the real added value of TRUDE is this broad systems transdisciplinary approach. Can we understand the complexities and nuances of this problem space by taking a multi-pronged attack, if you like, on trying to explore and understand it? We're working in co-production with project partners in Bristol City Council and also Greater Manchester Combined Authority. In Bristol City Council, we're using large-scale housing development as an exemplar of an urban development decision-making space. And in Greater Manchester, we're using an initiative called Streets for All, which is about transport design. We have 2 excellent researchers in residence who've taken quite a lot of time to develop trust and relationships in our case study sites. A key objective of UKPRP is to produce meaningful, impactful science that will allow project partners and stakeholders to work better, using good science as the foundation. And our researchers in residence are the constant reminder in meetings and the check and balance for us to do that in meaningful ways. In advance of the interviews, we have conducted a series of policy reviews where we've identified hundreds of actors and stakeholders working at local, national, international level. When we came to produce our interview sample for the interviews, all of our 8 teams used these 2 criteria to select people. So our respondents represent people who have formal influence. These are the people actually making decisions in the public, private, and non-public sectors, community interest groups. Do they have a formal position? Are they actively involved in the decision-making process? And we have also interviewed people with an understanding of the system, experts, academics and think tanks who understand the system from the outside. There's no need to take in this detail, but what this slide illustrates is our real commitment to transdisciplinary working. It would have been much quicker and easier for all our teams to go off and do their own work based on their perceptions of the problem space and what's important for their worldview. We haven't done that. We have right from the start tried to produce a collective understanding of the problem space. We've used literature and our research questions to guide the data collection process. We've produced a set of research questions that are guiding all the teams, and we've used that to design our interview questions. And this simple diagram was the product of a lot of work. Working across disciplines is not easy, but the added advantage means that once we bring the data back together, it talks to one another, and we can develop this systems approach to understanding the problem, thinking about potential avenues for something new, and how we might design interventions. So this is the number of interviews we've done by sector. The interviews took place in spring of this year. We've done 127 in total, and we've asked questions to key actors about how do you make decisions, What do you perceive as the barriers to healthy urban development? And what are the opportunities for change and doing something new? And at this point, I'll hand over to Krista to talk about some of the findings.
Wonderful. Thanks so much, Sarah. So with this in-depth data set that represents a broad set of system actors, we thought one of the best ways to be able to organize and understand that data was to organize it according to 4 subheadings. Now we are at the process at the point now of finalizing these findings, so the way in which we present them may shift a little bit, but this will give you a really good flavor for what's in the data. So the first subheading is insights, and insights we defined as being something that, say, 1 or 2 actors within the system talked about. It might have been an issue that was different to what was happening across the kind of main data set, or it could have been a way in which those actors were talking about the data that was different and helped us to see that the rest of the data differently. But what's fascinating about this is that when we talk to our teams about what we should put into this category, they said there really isn't anything that fits at this higher level of aggregated data. And what makes that such a fascinating insight in and of itself is that when we talk across to actors across the broad system, what we have is quite general agreement about what those foundational issues are that are impacting health and its inclusion within urban spaces, which is actually a fascinating finding for us in terms of moving forward. So there's general agreement across the system about what those foundational root cause issues are. The second the subheading is patterns. So you can see that there are 9 here. I'm not able to speak to all of them in the time that we have available, but I'll speak to a few of them again to give you a flavor for what's in the data. So if we look at the final point on the slide, which is decision-making power, this represents the idea that many stakeholders within the system, so many of those system-wide actors that we talked to, didn't actually feel that they had power to bring health, well-being, or sustainability into their work. They thought it was somebody else who had that final decision to make. So they could nudge, they could suggest, they could try to encourage, but actually the decision wasn't up to them. It was up to somebody else. And it didn't seem to matter where we talked to people within that supply chain. So whether we talked to whether it was business consultants or whether we talked to developers or local councils, the decision seemed to sit elsewhere in terms of their perspective. Now you can see with some of these other patterns, there's a blue, a green, and an orange one. These ones also represent problem spaces. And problem spaces we've identified as being where a nexus of issues has come together to create quite thorny sets of issues, but where we think there might be some meaningful room for engagement. So I'm going to talk about these as part of problem spaces on the next slide. So next slide, please, Sarah. So if I talk about policy alignment and coordination first, many actors within the system are concerned about policy alignment. So they see policy as being quite confusing. They see there as being many gaps in terms of the policy provision and enabling people to game the system. There's a lot of confusion. There's a lack of understanding of what the priorities are, and they're complicated and expensive to try and navigate. And so this was true whether they were national policies, local level policies, but equally there was also some data that talked about the same kinds of confusion and the same kinds of problems existing in the the private sector with regard to the different kinds of industry level tools that are available there as well. The second point, diversity and inclusion, this refers to, the first part of it refers to probably what you would expect, which is the fact that system actors repeatedly indicated that we needed to have more and more diverse voices represented within the system. So we needed to bring people who are not currently engaging this, with the system into the engagements that are happening with regard to urban spaces. But the second part of this is about diversity of thinking. So many people also indicated the fact that there's a lot of fear of change. There's risk aversion. There are a lot of short-term types of thinking that are actually causing people to fall back on business as usual. So let's do what we've always done because it's easier, it's less scary. We think that's what people want anyway. So it gives us an opportunity to just do the development or do the project that we need to do without having to worry about thinking differently. The final problem space I'm going to talk about today is understanding health impacts. So across the data set, again, people didn't feel that they had sufficient information about the health impacts of what they themselves did. Oftentimes, they would have liked more information to be more certain about, for instance, if they changed a design for a house, how that might have an impact on health further down the line. But it was also about having data that was then convincing to those decision makers. So remember from the previous slide where I said that people thought the decision about including health, well-being, and sustainability wasn't really up to them. It was up to somebody else. They didn't think there was sufficient data to make the case strongly to convince that decision maker. So what then did our interviewees say were some ways of trying to intervene in these really naughty, quite wicked problems? Well, when it comes to policy alignment and coordination, obviously they said, well, let's align the policy, right? Simply said. But one of the key areas that people talked about quite often was bringing together health and transport. So people thought those two groups, even just talking together, would have a substantive impact. But they were talking about statutory engagement with health authorities, looking at Section 172 of the Companies Act and really encouraging companies to take that seriously and to enable them to bring health, sustainability, and well-being more firmly into the core of the decision-making that they do. But of course, to be able to align policy and to fill these policy gaps, you need to have improved collaboration. And so, of course, this green part then, engender collaboration. This links into this policy agenda. So how do we bring those disparate voices? How do we bring the lived experience of people in urban spaces to bear on that decision making? So they were talking about a number of different kinds of engagement. So for instance, one suggestion was housing management boards as a forum for putting stakeholders together. So there are a number of these kinds of suggestions, but ways of bringing people into the room to discuss, and hopefully by bringing in those more diverse voices, there's an opportunity for broader diversity of thinking as well, and starting to break some of those dominant scripts of thinking around urban spaces and how we design them. And the final one around filling the evidence gap. So this is linked to understanding health impacts. If we need more information about the health impacts, let's fill that gap. Okay, most people were looking for quantitative data that was clear, creating clear links between the health impact and the design component. So whether that's designing a policy or designing of us practice. And oftentimes it was wanting that strong quantitative data was not only to make help people understand the relationship as clearly as possible between what it was that they were doing in their own practice, but they felt that that quantitative data was going to be more effective in changing the decision maker's mind. So there was a bit of contradictory. So there was a few people who said maybe quantitative data, we need to be careful because not necessarily all health impacts can be articulated in a quantitative way, but there was certainly a strong trend towards how do we get some more of that clear quantitative data. So overall, our findings tell a really interesting story. They tell us that there is broad agreement across system actors as to what those foundational root causes are for the reason why health and sustainability and well-being are not being included as they might within urban development, as well as some of those knotty problems where there's going to be a great opportunity for us to get involved and intervene. Next slide, please, Sarah. So our next steps, the first is we're going to be integrating the data sets that we have. We have this data set that we've been talking about here, which is the interviews. We have a systems mapping data set and a researcher in residence data set that Sarah was talking about in terms of our project partners. So bringing all of that together to create that strong foundation for the co-production of our interventions, which is going to be bringing together our project partners, relevant stakeholders to identify which of these particular problem areas we're going to focus on, those knotty problems, and to then work with them to critically evaluate the potential interventions that would go into that space to make sure that we are chipping away. So this final goal of ours in TRUDE, to chip away at these knotty problems to try and shift this monolith of a system in a way that starts to improve health benefits in a meaningful way and health inequalities to make sure that we're addressing the differential impacts of urban design on health. Next slide, please, Sarah. If you have any questions outside of this presentation that you'd like to ask, please contact us here. Otherwise, we look forward to Angela's comments and to those from the audience. Thank you for your time.
Thank you very much, Sarah and Krista, for that really it's a lot of complexity to cover in not a lot of time. And just a reminder to everybody to please do feed in your question through the Slido or the closed captioning, and we'll answer as many as we can in the final Q&A session that we have. It's now my pleasure to introduce the second of our talks and introduce Angela Hans, who, as I've already mentioned, is a Public Health Programme Manager in the Healthy Places and Communities team at the new Office of Health Improvement and Disparities, who's going to talk to us about some of the policy challenges. I'm not sure if you'll manage to cover them all, Angela, and the implications within the sector. So over to you, Angela. Thank you.
Thank you very much. Can you see the slides okay?
Yes, we can. They're fine.
Lovely. Thank you very much. And good afternoon, everyone. Thank you ever so much for inviting me here today. I'm really excited to be here, and I've very much enjoyed hearing about the TRUDE project's early findings. And Sarah and Krista, it's fascinating work, and really interested to hear more about the project as it progresses. So I'm here to talk to you on behalf of the Office of Health Improvement and Disparities, or OHID. And for those of you who haven't heard of OHID before, we were known as Public Health England until a few weeks ago. I'm the Public Health Programme Manager in the Healthy Places and Communities team, and I'm going to tell you a little bit about some of our policy challenges in the spatial planning and healthy places sector, and some of those associated health impacts and some of the implications of those. So if you work in public health, I'm sure you've seen this before. It's the Barton and Grant wider determinants of health map, and I'm really sorry if it's familiar to you, but for completeness and just in case anyone here hasn't seen this before, the wider determinants of health are those health effects that buildings and outdoor spaces and transport have on people's health. So we do know, as we've heard, that as well as somebody's individual characteristics, their lifestyle, someone's health is also closely linked to things like their local community, their social environment, and throughout our lives, the conditions we experience every day will impact our health. So our role in the public health team within Healthy Places is to influence these 3 bullet points at the bottom, which is avoiding ill health and early deaths, supporting and enabling good health, and reducing health inequalities. And if you look at the map, the wider issues in the darker blue of the circle, the built and natural environment, are the focus of our team. So we look at these issues upstream, and we're hoping that we're able to tackle the causes of poor health, and overall that can lead to population health improvement. So taking a look at the financial challenges and opportunities, which links nicely with Sarah and Krista's work on the economic valuation tool. This slide shows us that there was a pre-pandemic public sector expenditure on the NHS of £129 billion per year. And of that, 4.5 million is on public health or health prevention. But then on the other hand, 70 billion plus is spent on the built environment. Some of that being from government, but largely from private developers. But the interesting thing is that this is regulated by the government, mostly through the spatial planning system. So it doesn't quite match up. We're building this car-dominated society. It makes us less active. And obesity is costing roughly £5 billion a year. That could be doubled in 30 years. Physical inactivity is costing us £7.5 billion, and poor housing £2 billion. And just improving communities could save us £500,000 a year. So it's really important that we start to influence this process. So our team's work on Healthy Places is underpinned by an evidence review that we did a few years ago. And it sets out the characteristics within the built and natural environment that are associated with health outcomes. So things like walkability, connectivity, cycling infrastructure and access to green spaces that we've heard about already all influence health and well-being. And we also see that the government has stated planning policies and decisions should aim to achieve healthy, inclusive and safe places. But in reality, we're not really sure whether this is actually happening on the ground in local authorities. And certainly from my time in local authority planning, I'm not convinced it's happening everywhere. And hopefully that's what the TRUDE project is going to help us with. So I just wanted to give you an idea of how the planning process works. It's useful to say that it's different across the 4 nations of the UK. My experience is in England, so if anybody wants to be put in touch with one of the other administrations, please do let me know, because I do work closely with counterparts in the other administrations. So in terms of England, the government has produced one major planning policy document, which is known as the National Planning Policy Framework, or the NPPF. So that's got multiple chapters in it. And our team's interest is in chapters 8, 9 and 15, which are listed there, and they're all relevant to healthy places. And then from this policy stems a series of planning practice guidance. And that is some guidance which planning officers should be using to support their decisions when deciding how the built environment is going to be designed. So the question is, why isn't this guidance always percolating down into local authority planning policy and action on the ground? And hopefully that's where our team can work with this TRUDE project to find out. I'm presenting a piece of work that some of my colleagues carried out a couple of years ago, and found quite similarly that the public health evidence is quite difficult to translate into practice. I found this to be true personally, and again, it may be linked to that lack of capacity and resource and the gap of understanding between planning and public health. And we've certainly identified that there's a language barrier to address, which can be quite a challenge. Something that I'm really passionate about is that there's a lack of monitoring and evaluation of planning decisions for health outcomes. So if we can do more of that and develop interventions to make sure that happens, it's going to be of a huge benefit to us. We have seen a lot of silo working in both local and national governments. It doesn't help collaboration. So developing interventions to support that kind of collaboration will be of most benefit to us. So that's where my team comes in. So we only joined OHID a few weeks ago. So you can see on the screen our draft plan. I expect it's going to change, and I really hope we can start to address the issues identified both in our experience and the TRUDE project. I'm not going to go through this in fine detail, but I just wanted to present something to you to show that we've got a plan of action, even if it is in draft at the moment, and hopefully we'll be able to develop this as time goes by. We hope to achieve our goals of reducing the contribution our built environment makes to ill health, and increase that contribution to improving health and health equity. And we want to do that by doing some more evidence reviews, providing some technical support and guidance to local authorities, local systems, and offering some opportunities as advisors on research projects such as this. And we do have a wide stakeholder group, and we want to improve our collaboration with those as we move forward as well. So in terms of the Healthy Places and Communities team programme areas, this gives you a little bit of an idea of the individual programmes and projects that we're working on. On the top, we have the Healthy Places framework and an integrated care systems deep dive. I thought it would be useful to describe the Healthy Places framework because the evidence has told us that practitioners are struggling with quite a lot of different tools and guidance and frameworks. So the team is commissioning an academic partner to do a review of tools, and we hope that that will lead to developing a framework for healthy places, which could potentially be adopted by local authorities. So apart from that, we have the 5 programme areas where we hope to influence policy across government. And each of these programmes, so that's spatial planning, nationally significant infrastructure projects, housing, transport and active travel, and the natural environment. So we want to look at at an overall aim of embedding health and well-being into the policies and projects that are being carried out across government. It's not easy, so we're starting with the evidence base, and it's very much relationship building too, and using our influencing and negotiating skills to improve the understanding of health inequalities across these different government departments. Sometimes it can be quite easy to do, but sometimes it could take weeks or even months, depending on the individual behaviour change of the professionals that we're collaborating with. So it can be quite tough, but it's so worthwhile when it starts to take shape. So, for example, some of my work with active travel has been quite a slow burner with the Department for Transport. It's quite difficult to get a seat at the table, but once we were at the table, it was difficult to get heard. But over time and with some perseverance, we've been able to make some headway. And this has finally led to health and well-being being included in the government cycling and walking plan. And I'm now part of Department for Transport Cycling and Walking Board, and which that means I'm making decisions on future policy development to make sure health is included in that. So we're not there yet. We have some way to go with inequalities and behaviour change, particularly with children travelling to school. But I think we're pushing at an open door, and we've got lots of proposals for 2022. And hopefully the same relationships will be forged with colleagues in other departments that have responsibility for our other project areas. So we're working to develop the evidence base and supporting those local public health teams to build relationships with the planning officers in their areas. And there is a lot of interest, and hopefully we shall be building the evidence on the interventions that work. So what have we achieved so far? Well, in the last 3 years that I've been in this team, we are still seeing inequalities widening, unfortunately. Obesity levels are still going up, and COVID hasn't helped perpetuate these inequalities, but we still have some challenges in how to measure health improvement as well, because we are struggling with our monitoring and evaluations. So in terms of policy outcomes, national policy levers on health are much stronger. There's a stronger political narrative on healthy places, which stands us in really good stead. And we have improved local policy frameworks for health and working towards embedding health in impact assessments as more public health teams are involved with the planning process. And then upskilling our next generation of planning and health workforce. So what next? We've got a number of proposals for the future, looking at greater clarity on health and wellbeing impact of the natural environment, alongside embedding health into policy and programmes. Reducing inequalities is key for us, so that we can help those who need it most. And then we need to make sure we assess how people's health is going to be affected. And we're very lucky that across national government and local government, we are starting to make those relationships. So that's really all I wanted to say. This slide's showing just a few of our team's evidence reviews and guides, which you may wish to refer to if necessary. And I'll finish up with a link to our knowledge hub, which is where we share our updates on legislation and guidance, evidence and publications, etc. on healthy places, and host some good discussions too. So please sign up if you're interested in hearing more. So thank you very much for listening.
So thank you very much indeed, Angela, for a really interesting insight into a different take on sort of decision making, particularly in grappling with the planning environment and all those interdependencies. And speaking personally, it was good to hear your optimism that we've got the real prospect of making some positive changes. So we've had a good range of questions in, and we hopefully, with the help of my panelists, who are indeed going to do the heavy lifting, if they'd like to switch their cameras on, we'll get through as many of your questions as we can. Some I think are relevant to some of the others, but we'll make a start. And the first one, and I guess I'll put it to Sarah and Krista, is how are you involving individuals in research to explain needs, not just planning organisations?
Krista, shall I jump in? So at this point, it comes back to a team of experts that we have who are really interested in understanding the citizen's voice, and particularly marginalised groups. So one of the things that's come through from the interviews, as we know, it's usually the white middle class retired person getting involved in planning that has voice. And in Bristol, for example, the city where I've been doing my interviews, lots of evidence to suggest that those communities in affluent areas do a pretty good job of impacting on the planning process. Those people who have more issues with trying to get the children to school, survival, don't have the slack resource, the time, the cognitive budget to get involved. And we have a team led by Andy Gibson at the University of the West of England, who is really trying to access those communities and understand the way that they feel, the health impacts. How can we give voice to the family with asthma living on the side of a dual carriageway in a way that will land in the private sector, in Whitehall, and amongst our local decision makers? So it's a key strand.
I don't know if there was anything to add from your perspective, Andrew. It seemed that it was perhaps more directed towards Sarah and Krista, but if there's something you wanted to share, please do.
Yeah, I think our work tends to focus on the professionals, and then we hope that will then percolate down into local authorities, who may then have those interventions in place, as Sarah described, to bring in the local communities as and when required. And to add to that, our team does have a healthy communities strand as well, that we're hoping to use to integrate some of our work amongst communities. Thank you.
Thank you. So another question is, are there particular challenges in getting private property developers to help? And I don't know if you'd like to take that first. Perhaps Sarah and Krista in the first instance, and then Angela can decide if she wants to comment or not.
Shall I take this one, Sarah? Okay. I think it's a matter of incentives. So I think that there are a range of incentives that are and can be put in place that would encourage people in the private sector to be involved. So, you know, we talk about the economic valuation model that is being done in another part of TRUDE. And so this idea of understanding what the health impacts are from an economic perspective on, you know, a particular form of development or whatnot. So that's one way in which the kind of incentive, you know, it's about speaking to the language of the person that you're trying to influence, isn't it? And so there's that issue of how do we turn some of the data into numbers or into monetizing the health impacts. There was a number of interviewees who talked about the fact that that would be very useful for them. So how do we monetize? For instance, a window being placed in a particular position on a development or whatnot. So it's about the nature of the incentives, but I think it's also beyond that. So from my perspective, that's more of a short-term issue. So we've got incentives that we know work and that we can put in place. And we have some of those incentives that already exist, but it's also about starting to shift the mindset. So how do we try and help developers think just a little bit differently? So for instance, looking at Section 172 of the Companies Act and saying, okay, let's let's use that meaningfully, right? Directors have a duty to employees and to communities and to the environment. Let's make that a real thing when it comes to actually how they then go about the business of creating a development, for instance. So I think it boils down to incentives, but then taking it that next step and making sure that we can start to shift the way that people are thinking, the private sector is thinking about it. And so then the nature of the incentives that are necessary to do that.
Thank you. Angela, could I turn to you for a different perspective, or perhaps you echo Krista's words?
Well, I think Krista hit the nail on the head, really, in that it comes down to economics. And putting it from a developer's perspective, they want their developments to be viable financially. And if they have a finite amount of money, then the first thing that tends to slip is something that may be in relation to health outcomes. There is no legal requirement for health impact assessments to be conducted except for through an environmental impact assessment. And then we don't have the system skilled enough to be able to assess whether those health impact assessments are suitable. So although we have developers starting to understand health as an issue, and certainly some developers are very keen to integrate health, I think we need to understand, well, we need to help developers understand a little more about the inequalities aspect as well. So things like affordable housing, and helping people that most need to be helped to improve their health. And I don't think we're there yet. So our role will be to try and influence the new department called DLUC. They're the department responsible for spatial planning and housing, and help them to sort of travel through into local authorities, and influence that way. So hopefully that helps.
So there's a general question, which is, do you expect an impact of your work, your research on communicable health conditions, and what might that be? Who'd like to go first on that one? Sarah's nodding, so I might ask you to say your take on that question.
I mean, I think the world that we're in makes it impossible to ignore the pandemic effects. And indeed, unhealthy urban development has had an impact on people's experience of COVID and the fallout of COVID. So although our project originally was not intended to focus on anything communicable like COVID, it's a strand that we are mindful of and that we might well explore. If only as a lever and a tool to get people engaged. The government has woken up to it, of course, it's a huge crisis, but also in the private sector, the transition to home working, the lost days due to COVID, all of a sudden, these become particularly moot points for businesses trying to survive. So in TRUDE, we're interested in using anything as a lever and an incentive to get change, whether that turns out to be COVID, a narrative, the levelling up agenda, whatever it might be, we are interested in using it as a tool for persuasion.
Krista, do you want to say something briefly before I ask Angela for her thoughts?
I think Sarah's nailed it on the head, to be honest. I think that we'll use whatever we can to try and chip away at these really difficult, complex problems. And so if there's an angle with the communicable, through some form of communicable diseases such as COVID, we'll use it.
Angela, what's your take on the question?
Yeah, I think similarly, and we do have colleagues across the department who are collecting evidence on that very issue, because I'm sure you've seen some of the evidence in relation to potential risks of the way people's housing and people living in houses was impacting the spread of COVID earlier in the pandemic. So I can't speak wholly to that evidence because I don't think it's been completed yet. But there's certainly work going on in that space.
I mean, just as it's a related question, the antimicrobial resistance was mentioned as something. Is that something that your department or organisation might think about as its future plans as a major threat to human health?
There's certainly work going on in AMR across the department, but it's not something that I'm personally involved with, but we certainly have teams looking at it, particularly on the research side.
So we've had a comment come question. It says, and it says it's interested that people in the supply chain, and I don't know if it was this you or Sarah or Kristen mentioned this, thought it was somebody else's responsibility to factor in health considers. But the question is, how could this be addressed, do you think?
Would you like me to take this one?
Sarah, yes.
Yeah, okay.
I can see enthusiasm to tackle that topic.
Well, it was me that talked about the supply chain. I think it's an interesting question, isn't it? And I think that from my personal perspective, it's one of the key areas in which we're going to need to be thinking quite carefully about how we intervene. So how do we enable people to make that decision? How do we enable people to take, because each of the different disciplines that are involved in the provision of some kind of urban space, each plays a part of that, creates a part of that puzzle, right? Everybody has some power that they can use. And how do we connect those dots between the different actors? So some of it will be through the alignment of policy, as we've discussed, but I think also some of it's going to be through that ability to listen a little bit more closely, having the bandwidth and the incentives there to listen more closely to what other people are saying and bring two decision points together as one, and thereby combining some aspects of power. And I know that that's a very vague, overarching answer, but it's something I think that we're really going to be looking at in terms of how do we empower people to say, yes, let's include health, well-being, and sustainability.
Can I just add, Philippa? I mean, just
yes.
In relation to the incentives, the whole problem about wicked issues is where does accountability land, and what is going to make busy professionals with limited resources and a million things to do actually take something that's really complicated and challenging by the horns and run with it. So I think it's about trying to bang heads together, for want of a better phrase, and where can that initiative come? Does it need to come from the Treasury, for example, my world of Whitehall decision making, and the Treasury providing financial incentives for the breakdown of siloed working? Can you use local strategic leadership through elected mayors to really make sure that this agenda has prominence at a local level? Is it something internationally in terms of the supply chain? So it's about trying to find those critical leverage points where you can incentivize people to get to make those difficult, time-consuming decisions that we know will have really positive outcomes.
Is there anything you'd like to add, Angela, or do you think we've covered this topic as much as we can?
Well, I think something that may help on this going forward is that the role of the Director of Public Health has appeared so much more over the last couple of years because of the pandemic. And that role is crucial in the education of professionals, particularly in local authorities. It really is their role to kind of spread themselves across local authorities and make sure that health and well-being is embedded in the work going on. And it's going to take years. And there's a plethora of professions that we could upskill. And one example I can use is an e-learning module that we developed a couple of years ago to upskill people like health visitors going into someone's house to help them understand the risks of the poor housing, and then teach them how to refer that on to the relevant people, because there was a lack of understanding who was responsible for somebody's poor housing if they're going in to meet a new mum or somebody that needed care after being discharged from hospital. And so those are the kind of very large issues that we need to address. So yeah, we're certainly looking, and that's the role of OHID going forward, I think. And we just need to work with our research partners to find out what actually works.
Sadly, I don't think we've got time for any more substantive questions. There's one that a few people have posed, which I'm going to take a chair's privilege to answer, and I think I've got the answer right. A lot of people are asking if the slide pack will be shared, and since this recording is obviously going to be shared, I think we can confidently say yes. And then the second question that a few people have mentioned, and I feel I should therefore ask it, is it said that the qualitative findings, this I think was for TRUDE, were really interesting. And is there anywhere currently online, you know, in the form of reports that we can read more about these qualitative themes that have been identified?
Shall
So,
I take this one,
yes,
Sarah?
please do, Krista. Yes.
We are at the point of finalizing these findings at the moment. So we're just going through a final process of getting feedback from different parts of TRUDE itself and our external advisory board, etc. And so once that process is complete, Sarah and I will be leading on organizing everything into a final form that can then be put on our website and otherwise communicated. So watch this space early next year.
But thank you all very much, and apologies that we didn't manage to get through more of the questions in the time that we had available. I'm sure between us, the organising team, you know, we'll certainly make sure that the questions are circulated, and it may well be that they stimulate discussions and follow up things that we may get to find out about or not so they won't be lost. So thank you all very much for listening in to what I hope you all agree was a really interesting set of presentations and a really thought-provoking set of questions. I learned a lot. UKPRP, as I say, you know, has set its agenda out very ambitiously. We've covered a lot of ground and where there's a lot more to do. So those of you that, you know, are perhaps unfamiliar with UKPRP or consider yourself part of the UKPRP community, you know, we look forward to continuing to act with you where we all work together to really, I think, raise the importance still more of prevention and public health. So thank you all very much indeed for listening, and perhaps you can mention the recording to other colleagues so we disseminate the message still ever wider. Thank you all very much.